Hello everyone. So my topic is stressed, moody or hormonal. Very often we all see people saying she's so moody, she's so stressed. So as we delve deeper into the topic, we'll see whether it is stress, mood swings or something deeper and more complicated than that. So these are the contents. Hormone fluctuations that women have every month, we are all aware of these. Estrogen rise happens pre-ovulatory leading to ovulation, after which corpus luteum is formed, which releases progesterone. Reproductive steroids have been seen to influence ADHD symptoms. Decreased levels of estradiol in the context of increased levels of either progesterone or testosterone were associated with higher ADHD symptoms, particularly in people who had high trait impulsivity, and phase analysis suggested an early follicular and early luteal or post-ovulatory increase in ADHD symptoms. The role of estrogen also played an impact on binge drinking and mean proportion of alcohol consumption in women, which saw a pre-ovulatory rise in episodes of binge drinking. Furthermore, if the pre-ovulatory rise was seen on weekends, the uh, proportion of women that consumed alcohol to cope with symptoms and anxiety was more. Now, incidence of depression across the male life cycle. In men, the incidence of depression rises in puberty and then is essentially constant throughout life, despite a slowly declining testosterone level from age 25 onwards. Whereas in women, the risk of depression varies across the life cycle. Women's vulnerability to the onset and recurrence of depression is seen first with the onset in puberty and young adulthood. Premenstrual syndrome and menstrual magnification are harbingers of future episodes, or there is incomplete recovery from prior episodes of depression. And there are two periods of high vulnerability that of women will have depression, and these two situations in life are the postpartum period and the perimenopausal period. Psychiatric history further predicts a risk of perinatal depression. Women with a history of major depressive disorder or depressive symptoms which are present during pregnancy or postpartum depression are at an increased risk for perinatal depression. History of postpartum depression in previous pregnancies is the greatest risk factor. Estrogen also has major effect on cognitive functions. So the mid of this particular graph indicates the approximate range of optimum executive functioning. Increase in dopamine or norepinephrine concentrations, estrogen level, and stress can shift the prefrontal cortex dependent executive functions to the right of the graph, which indicates a decline. Now a little bit about premenstrual mood syndromes, further to emphasize on the fact whether it is mood swings, it is stress, or something deeper than that. Mild mood changes that occur should not be labeled as a disorder, and they are common. These symptoms are less intense and do not result in significant distress or impairment, as opposed to premenstrual syndrome, which has been defined as American College of Obstetrics and Gynecology as one of the affective or somatic symptoms that are listed, which should be present in 3 prior menstrual cycles. Another category of disorders is mental behavioral and neurodevelopmental disorders, including mood disorders that are exacerbated premenstrually. We have to exclude these things. Premenstrual tension syndrome. This includes women that experience cyclic, emotional, physical, or behavioral symptoms that interfere with their lifestyles during the luteal phase of the menstrual cycle, and they are diagnosed and treated as premenstrual tension syndrome. This is in contrast to premenstrual dysphoric disorder, which is more severe. Again, I want to emphasize on a point that neither PMS nor premenstrual exacerbation of pre-existing psychiatric disorders is a recognized psychiatric disorder. Premenstrual dysphoric disorder, this is a recognized entity. It affects 2 to 8% of women during the reproductive years. It occurs much less frequently than PME or PMS. Risk factors include high potassium diet, metabolic syndromes, increased BMI, nicotine alcohol use, childhood trauma, low socioeconomic status, white race, and family history of premenstrual dysphoric disorder. The required features, that majority of the menstrual cycle within the past year, there should have been a pattern of mood, somatic or cognitive symptoms. And the symptoms should include one affective symptom like mood lability, irritability, depressed mood or anxiety, and additional somatic or cognitive symptoms. And the symptoms should not be due to another medical disorder or another mental disorder, and should result in significant distress or impairment. Management for premenstrual dysphoric disorder includes exercise, adoption of a complex carbohydrate diet, CBT, serotonin reuptake inhibitors, or combined hormonal contraceptives. Second line, increasing the dose of hormones or SRIs. And the third line, GnRH analogs. Perinatal psychiatric disorders are further another category of disorders that are not just mood swings or are not due to stress. So postpartum withdrawal of estradiol and progesterone occurs rapidly within the first 2 to 7 days postpartum, inducing depressive relapse in women with a history of postpartum psychiatric disorders. Reproductive hormonal fluctuations are associated with disruptions in CNS corticolimbic connectivity that promotes healthy emotional processing. Dysregulation of allopregnanolone plays a role in the development of perinatal psychiatric disorders. Risk factors include mothers with a personal or family history of depression, sleep deprivation, high social stress, marital discord, minority status, adolescence, that is pregnancy that occurs during adolescence, and neuroticism. So perinatal mental disorders range through a wide array of disorders, but we shall only be covering the 2 or 3 more important ones and the ones that occur more commonly. So baby blues, it is a constellation of mood symptoms experienced by women. It is seen very commonly, occurs in up to 80% of women, and it occurs in the immediate postpartum period. It includes transient symptoms of mood shifts, irritability, anxiety, insomnia, lack of energy, loss of appetite, and the feeling of being overwhelmed, particularly about newborn caregiving tasks. Baby blues are transient. The onset occurs mostly on the 3rd postpartum day, peak by day 5, and resolve by day 10. And it has been estimated that 20 to 25% of women who experience baby blues will experience major depression in the future. Treatment involves psychoeducation, validating the experience, and careful monitoring for worsening or prolongation of symptoms. Perinatal depression, earlier we used to call it as postpartum depression. Now the term is called perinatal depression because perinatal onset recognizes symptom onset anytime in pregnancy till 1 month postpartum. Onset during pregnancy is more likely in women with a history of depression. For women without a history of depression, the onset is more common in the 1st month postpartum, and it also increases the risk for a future diagnosis of bipolar disorder. Depressive episodes that occur postpartum are more likely to have characteristics of obsessive compulsive disorder, which includes intrusive violent thoughts and psychotic symptoms. Postpartum depressive syndromes affect 15% of mothers, and the rates are triple among low socioeconomic, minority status, and adolescent mothers. Risk factors include personal or family history of depression, personal history of previous depressive episodes like we saw in the slide before, and women that face multiple or severe psychosocial problems, patients who have a history of trauma, chronic interpersonal difficulties, and history of childhood sexual abuse. Pharmacological treatment for this is something that is very controversial, because if we treat it, we have a lot of risk, and if we don't treat it, still the risk is there for the female. If we treat, there can be cardiac malformations, there can be newborn persistent pulmonary hypertension, which is seen with the use of SSRIs in the third trimester. There can be neonatal withdrawal syndrome. The child can be born prematurely and the birth weight can be low. There can be neurodevelopmental abnormalities. And if we don't treat it, there is risk of relapse of major depression, there's risk of increased suicidality, poor self-care, poor motivation for prenatal care, among other things. So for management, amongst SSRIs, sertraline seems to have the least placental exposure, and most data supports the use of fluoxetine. Brexanolone is a newer compound which has been approved by the US FDA, and zuranolone, but the use is limited due to its availability and high costs. Non-pharmacological treatments include CBT, interpersonal therapy, mindfulness, light therapy, supplements. Supplements can be used as adjunctive therapy. There is not much evidence to support its use as mainstay, and research is too limited on effects of exercise, yoga, massage, and acupuncture. ECT, that is electroconvulsive therapy, it has not shown to cause any harm to the mother, but it is given under general anesthesia, which has its own risks. And ECT can be used for women with severe depression, mixed affective states, mania, catatonia, or when the physical health of the mother or that of the fetus is at serious risk. Postpartum psychosis, it is most severe and very rare as well. It presents within the first few weeks following delivery. The symptoms can be seen, that is depersonalization, delirium, agitation, insomnia, delusions, and affective symptoms predominate, which is why it is an affective psychosis. Women with pre-existing bipolar disorder are at very high risk, and women with new onset postpartum psychosis are eventually diagnosed with bipolar disorder in 50 to 80% of cases. Now, postpartum psychosis is a medical emergency because of the potential risk of infanticide or suicide, and requires urgent referral to a psychiatrist, and hospitalization is needed. Mostly lithium is started in such patients. This is the rest of the treatment, which I'll skip. Now, menopausal transition is another such aspect in a woman's life where we often see people saying that one is stressed or moody. Again, we need to see whether it is just a mood swing or it is something more than that. So menopause is the cessation of ovulation and absence of menses for 1 year. It is due to the depletion of responsive ovarian oocytes and generally occurs between 47 to 53 years of age. So perimenopause describes the period of hormonal fluctuation eventually leading to amenorrhea. Women frequently experience somatic and psychological symptoms during this period. Physical symptoms include vasomotor symptoms or hot flushes, which are the hallmark of the postmenopausal transition. It is distressing sequelae and consists of sudden episodes of perspiration, flushing, chills, clamminess, anxiety, and a sense of extreme heat. Symptoms last for 1 to 5 minutes and occur daily in over 85% of women, and in some it can occur up to 10 times daily. Lifestyle alterations mostly help, or hormone therapy with estrogen alone or with progesterone is indicated. If there are contraindications to hormone therapy, SSRIs and SNRIs can be used. Menopausal status and depression. So there is a 2 to 4-fold increased risk of depressive symptoms during perimenopause. And other risk factors for perimenopausal depression include personal history of mood disorder, previous history of reproductive related mood disturbances and psychosocial stress. Perimenopausal cognitive changes have also been seen. Women struggle with verbal recall, that is immediate and delayed recall is affected, and processing speed is also affected during perimenopause. Some studies have used atomoxetine and lisdexamfetamine, but the limitation remains that it causes hypertension and tachycardia. Antidepressants can also be used for patients who have cognitive symptoms in association with comorbid depression. These are my references. Thank you.
Thanks, ma'am. Thanks for such a nice presentation. Ma'am, you have mentioned that hormonal treatment can be given in the menopausal females. So is there any, I mean, for how long can be given, and is there any criteria that?
So since I am a psychiatrist, if a patient would require hormone therapy, I would refer them to an endocrinologist. So instead of initiating it myself and going in for whatever investigations are needed.
Because hormonal therapy will have side effects.
So we will not. We start medication for patients who have contraindications to hormone therapy, or patients who have comorbid depression or have cognitive decline. So for them, we would like to start either SNRIs or SNRIs instead of going in for hormone therapy.
Okay. Thank you.
Thank you.